The Subcommittee on Health, Employment, Labor, and Pensions will come to order. I note that a quorum is present, and without objection, the chair is authorized to call a recess at any time. The subcommittee is meeting today to hear testimony on solutions to address healthcare challenges facing working families and small businesses. So good morning, everyone, and welcome to today's hearing. I can remember President Obama's promises regarding Obamacare. If you like your plan, you can keep your plan. If you like your doctor, you can keep your doctor. Premiums will go down with the Affordable Care Act. Sadly, but not surprisingly, these were all misleading, empty, broken promises. In reality, Obamacare's regulations, mandates, inflationary subsidies, and misguided economic incentives have made health care even more unaffordable for Americans in the commercial market. It's no surprise that after 13 years of Obamacare, 3 in 4 Americans grade the healthcare system as a D or an F. Working Americans and their families are being crushed, and the American people are tired of their premiums going up. They are tired of their deductibles going up. They're tired of their copays going up. So today, in this first Health, Employment, Labor, and Pensions Subcommittee hearing of the 118th Congress, House Republicans will put forth a vision for free market healthcare reform that offers Americans much-needed relief. As a nation, we cannot settle for less than American exceptionalism, and we cannot turn to socialist countries for our healthcare advice. We need to listen to the American people. A vast majority of Americans are actually satisfied with their employer-sponsored insurance. 78% of employees choose to enroll in employer-sponsored insurance when given the option, but it's still too expensive. That's because Democrats have created an unlevel playing field for employers, and Democrats are not interested in addressing affordability issues for employers because the truth is they're scheming with the Biden administration to force every American into a government-funded, one-size-fits-all plan such as the Obamacare marketplace plans. By increasing Obamacare subsidies and overregulating the market, employer-based health care is becoming unaffordable, especially for small business owners. This is an intentional attack by Democrats on private insurance. It's the proverbial Trojan horse for Medicare for all. But one size does not fit all. The correct path forward is to respect and protect the free market and individual choice. Republican solutions seek to decrease health care costs while strengthening the private option that 159 million Americans who are covered enjoy today. Yesterday, I introduced the Self-Insurance Protection Act, and this bill allows small businesses to access stop-loss insurance, a form of insurance that helps employers self-insure and protects them from catastrophic health costs. Another reasonable solution is to increase association health plans. These plans allow Americans to save up to 50% on health care costs by allowing small businesses to band together to offer lower-cost health insurance like large employers are able to do. The free market and increased competition will lower prices if we are bold enough to let them do that. A free market only works when there's competition, transparency, and accountability. Consolidation in the marketplace has led to dishonest billing practices. Dishonest billing occurs when big hospitals buy up independent doctors' offices and then charge higher prices for doctor services as if they were occurring in a hospital setting. Hospitals should bill the proper rate for their service and not use bogus facility fees as an excuse to tack on thousands of dollars in extra charges. Finally, we should ensure that workers retain access to the deregulated telehealth options they enjoyed during the COVID-19 health restrictions. And with that, I look forward to the hearing today, and I yield to our ranking member.
Thank you, Mr. Chairman. I want to thank the witnesses for being here. Appreciate the comments as a former small business owner, a restaurant owner. 13 years ago, 48 million Americans, more than 14% of the U.S. population, did not have health coverage at all. Insurers could deny people coverage because of pre-existing conditions. Insurers could charge women more than men for health insurance. And most individual market plans only covered a fraction of prescription drugs. Today, more Americans are covered and have better health care protections than ever before. This is a direct result of the key steps Democrats took to expand and protect access to affordable, high-quality health care coverage. In 2010, President Barack Obama signed into law the Affordable Care Act, which provided millions of Americans with access to quality coverage and key consumer protections. Thanks to this milestone achievement, insurers can no longer deny people coverage for pre-existing conditions. Plans must cover preventative services like cancer screenings and birth control at no cost. And mental health and substance use disorder treatment is considered an essential health benefit. During the last two Congresses, we built on the progress of the ACA and took decisive steps to lower healthcare costs even further for Americans. We passed bipartisan legislation to protect Americans from surprise medical billing and improve transparency in healthcare. And congressional Democrats passed the American Rescue Plan, which enhanced the ACA tax credits to lower monthly costs for low-income individuals and eliminated the subsidy cliff so that more low and moderate income individuals could get coverage. Lastly, Democrats passed the Inflation Reduction Act. This historic legislation extended the premium on tax credit enhancements, capped the cost of insulin for people with Medicare, and for the first time directed the federal government to negotiate lower prices for prescription drugs covered by Medicare. These victories have yielded real results, lowering costs and making healthcare more affordable. Clearly, we have a difference of a perspective. In August, we brought the number of Americans without health insurance down to the lowest level ever. In fact, during the most recent open enrollment period, a record 16.3 million people signed up for coverage, and the average consumer has saved hundreds of dollars a year in premiums. Unfortunately, our progress under the ACA continues to be threatened. For more than a decade, our colleagues and conservative groups have worked relentlessly to erode or eliminate the ACA. Just last month, a conservative judge in Texas ruled to weaken the ACA's preventive services requirement. This has jeopardized access to preventative care ACA for millions who otherwise may not be able to afford it. For context, this is the same judge who attempted to eliminate the entire ACA before it was upheld by the United States Supreme Court. I'm concerned about the development since I know that many of us may not see eye to eye on many things, but the value and importance of preventative care is undeniable to ensuring the health and well-being of our country. Moreover, we know that preventative care can result in lower costs by managing chronic disease, supporting mental health costs, and more. And it helps employers in employer-based health care. Unfortunately, many of our colleagues' proposals that we will hear today could undermine affordability and ultimately make it harder, not easier, to access quality coverage. However, we will keep an open mind and hope for progress and compromise with our colleagues. Expanding American health plans might provide lower premiums for some enrollees, but it would increase costs for other consumers in the traditional insurance market while adding nothing to address the underlying price of health care. This is a bad deal for American workers and for small business. Similarly, exempting telehealth plans from key consumer protection, such as mental health parity on the ACA's preventive services requirement, could expose workers to deceptive marketing practices that we have seen emerge when employers offer similar unregulated arrangements. Done properly, I think there's something we could look at. Instead of going backwards, we should be focusing on expanding quality health coverage for all Americans, workers and families, employers, and their employees. This Congress, we have several opportunities to make bipartisan progress, and I look forward to that engaged discussion, irrespective of where we may start on these issues. We can work together to strengthen the ACA and close the Medicaid coverage gap, which would help millions of people access subsidized coverage. We can bolster enforcement of mental health parity and ensure that health plans follow the law. We can build on our progress to empower the federal government and all Americans to be able to negotiate and have the benefit of lower costs for even higher quality and more controls over prescription drugs, many of which have started their discovery process with taxpayer investments at the National Institutes for Health. And we can increase transparency in our healthcare system and take a careful look at business practices that lead to higher prices and provider consolidation. Look, there are many different views on how to lower healthcare costs, and I think you've heard some different perspectives already from the chairman and myself. But I hope we can work together in good faith to deliver on our commitment, that we mutually agree that extraordinary healthcare in the idea of American exceptionalism is something we should all expect for all Americans. I look forward to the discussion, and I yield back.
Thank you, Ranking Member DeSaulnay. Pursuant to Committee Rule 8C, all members who wish to insert written statements into the record may do so by submitting them to the committee clerk electronically in Microsoft Word format by 5 o'clock 14 days after the date of this hearing, which is May 10, 2023. And without objection, the hearing record will remain open for 14 days to allow such statements and other extraneous materials referenced during the hearing to be submitted for the official hearing record. I will now turn to the introduction of our distinguished witnesses. Our first witness is Ms. Tracy Watts, who is a senior partner with Mercer and leads the company's healthcare policy and group benefits portfolio for regions of the United States. Thank you, Ms. Watts. Our second witness is Ms. Marcy Strauss, who is a small business owner and founder of Capital Benefits Group in Des Moines, Iowa. Thank you, Ms. Strauss. Our third witness is Ms. Sabrina Corlett, who's a senior research professor at the Center on Health Insurance Reforms at Georgetown University's Health Policy Institute. And our fourth and final witness is Mr. Joel White, who is president of the Council for Affordable Health Coverage. So we thank all of our witnesses for being here today. We look forward to your testimony. Pursuant to committee rules, I'd ask that each of you limit your oral presentation to a 5-minute summary of your written statement. And I'd also like to remind the witnesses to be aware of their responsibility to provide accurate information to this subcommittee. And I will first recognize Mrs. Tracy Watts.
Sorry. My name is Tracy Watts, and I'm a senior partner and U.S. Health Policy Leader at Mercer. I'm also the immediate past board chair of the American Benefits Council. I have more than 35 years of experience helping large companies design, finance, and manage their health benefit programs to control costs and to improve the health of their workforce. First of all, we applaud the committee's work and commitment to address healthcare affordability. We surveyed over 4,000 workers in late 2022, and 68% say they have challenges getting the health care that they need for themselves and for their family. Those most concerned with affordability are low-income workers, female workers, workers below the age of 25 and over the age of 44. Access to health care is also an issue. Finding a doctor, getting into a specialist, and getting time off from work to go to the doctor. In our employer research, 2/3 of large employers say that improving healthcare affordability for their employees is a very important priority for the next few years. A couple of examples of how they're doing that from a plan design perspective: 39% are offering a copay medical plan with little or no deductible. And from a contribution perspective, 15% are offering a free employee-only coverage in one medical plan. Given the outlook for faster healthcare cost growth, you might expect that employers would start to pull back on health benefits. But from our February-March survey on benefit strategies for 2024, it doesn't look like it. Nearly 2/3 say that they're planning to make enhancements to their health benefits as a way to improve attraction and retention. 2/3. I'd like to quickly touch on 3 topics associated with new legislation being introduced. Telehealth, when offered as an accepted benefit, meets a very specific need for certain employers, with large number of employees who are not benefits eligible. These are mostly part-time workers in retail, hospitality, and healthcare. But because of legislative uncertainty, we saw a decline in employers using this strategy. 7% use it in 2023. That's down from 17% in 2022. This is a benefit that's hugely valued by workers, but employers need permanent legislation for this coverage to be restored. As an example, we work with a large restaurant chain that extended telehealth to its part-time population. They viewed this benefit as a critical way to provide access to behavioral health services and appropriate medication when an employee who is not enrolled in the health plan gets sick. Next, with regard to legislation to ban unfair hospital billing practices, market consolidation and cost pressures have driven opportunistic billing practices by obfuscating where service is provided. Non-hospital services are billed using a hospital address as the place of service to optimize reimbursement at the hospital reimbursement rate. This raises prices for patients, it raises prices for employer plan sponsors, it raises prices for the federal government, and it's unfair. The most common example is the addition of a hospital facility charge on a bill for an office visit that takes place miles away from the hospital, or worse yet, for a virtual visit. Another example is an urgent care facility where care is billed as hospital emergency department visit. As a country, we can't fix this problem if we can't see the problem. The practices are increasing the costs for everyone, and if we're serious about managing costs and making healthcare more affordable, we need to address the core issue. We need more transparency on this. With regard to regulation of stop loss for small businesses, in the small 50 to 499 employee group size, 71% of those companies buy an insured plan, but 29% self-fund with stop loss. That number flips to 71% who self-fund with stop loss in the 500 to 999 category. Self-funding with stop loss allows companies to balance their financial objectives with their ability to manage risk, and it allows for greater flexibility to design benefits to address affordability and employees' needs. In this competitive environment, even with healthcare inflation, employers are looking for ways to enhance benefits and to address affordability, and that means workers win. Thank you for the opportunity to be here today.
Thank you, Ms. Watts. And now we'll go to our second witness, Ms. Strauss.
Good morning, Chairman, Ranking Member, and members of the subcommittee. My name is Marcy Strauss. I'm a partner and benefits consultant at Capital Benefits Group in Des Moines, Iowa. I'm grateful for the opportunity to testify today on behalf of small business owners nationwide who are struggling with increasing healthcare costs. For 4 decades, the cost of health insurance has remained the #1 problem for small businesses. The problem is now a crisis, with skyrocketing costs crippling Main Street. In fact, 98% of small businesses report that healthcare costs will become unsustainable in the next 10 years, threatening their ability to survive and remain competitive. This is why it's important that lawmakers focus on policies that empower small business owners and their employees with more choice and control over their healthcare decisions. For 20 years as a benefits professional, I've had the privilege of directly helping small business owners throughout the state of Iowa. I am boots on the ground, sitting across from business owners throughout the state. As employers look today, we're trying to find ways to help solve problems. Healthcare affordability is particularly important for my family as well, as we've experienced firsthand the importance of having access to quality care. We have 3 awesome children, Sid, Ella, and Libby. At just 7 years old, my twins were diagnosed with a neuromuscular disease, and this experience changed me forever. Since then, I have worked closely with the Muscular Dystrophy Association and was appointed by Governor Kim Reynolds to the Iowa Medical Assistance Advisory Council, working with Medicaid and MCOs in the state. I interact with small business owners daily, and I am a small business owner myself. I can tell you firsthand the overwhelming stress and anxiety employers are feeling right now. Small business owners care deeply about their employees, customers, and communities. They are constantly worried about recruiting and retaining employees while keeping their businesses afloat, and this is particularly challenging in this environment with sustained high inflation and acute workforce shortages. Employee benefits have always been important, but are even more crucial now. Our clients are more eager than ever to offer great benefits and to meet the needs of a diverse workforce while remaining competitive. But unfortunately, many lack the options. Many of our clients are forced to make tough choices every day. Some go without pay to keep their employees cared for and working. Others are forced to raise their prices or take a profit loss to contend with rising healthcare costs. For instance, in Polk County, Iowa, average small business premiums for a family have increased 85% in the last 8 years. For context, my family is currently enrolled in an individual grandmothered plan through Blue Cross and Blue Shield. We have a $2,500 deductible, and our monthly premium is $903 for our family of 5. A similar Affordable Care Act group plan today would be $1,952 in monthly premiums. The status quo is unsustainable. I hope this committee will advance policies that promote affordability and increase choices for small businesses. The following reforms would be a great starting point in providing much-needed relief for many of our clients. First, Congress should significantly expand coverage options, allowing small business owners, regardless of industry, to band together to form association plans and give them the same bargaining power big employers have. Congress can also expand protections for small business owners who choose to self-insure, expanding access to stop-loss and reinsurance. For instance, can reduce financial risk, enhance plan design, and increase the business's competitiveness. For an example, a recent client with 3 members was able to save $5,000 annually through a level-funded reinsurance plan. They were also able to lower the out-of-pocket maximum and co-pays for their employees. Employers can also benefit from greater transparency and competition in the industry. The system is too opaque to the detriment of employers. Increasing transparency in the pharmacy benefit manager markets and reining in healthcare hospital monopolies that engage in anti-competitive practices is key to lowering the cost of care. Lastly, lawmakers should reduce burdens on employers by streamlining and eliminating unnecessary reporting requirements. In conclusion, small business owners deserve relief from rising healthcare costs. The folks that I work with are not distant CEOs, but rather hardworking Americans betting on the promise of the American dream. They are in their communities. They go to church and school activities with their employees and their neighbors, who are also their customers, who they care deeply about. If small businesses thrive, we all thrive. Thank you for your attention to this important matter and for allowing me to testify today.
Thank you, Ms. Strauss. And now we'll hear from and recognize Ms. Corlett.
Thank you, Chairman Good and Ranking Member DeSaulnier. It is an honor for me to be part of today's discussion of policies to help reduce healthcare costs for working people and their families. In recent years, Congress has made several attempts to improve healthcare access, affordability, and quality. None has had a greater impact than the Patient Protection and Affordable Care Act. Today, Americans with employer-sponsored insurance take for granted many of the protections that they enjoy under the ACA, including protections for people with pre-existing conditions, coverage for young adults, cost-free preventive services, and caps on our annual out-of-pocket costs. More recently, the Consolidated Appropriations Act of 2021 now protects 177 million consumers from unexpected surprise medical bills and helps empower employers to be more effective purchasers of health benefits. And last year, the Inflation Reduction Act helped advance the coverage and affordability gains under the ACA and is lowering prescription drug costs for Medicare enrollees. However, challenges remain. Since 1999, employee contributions to premiums have increased by about 300%. And average deductibles for a single worker have risen from $303 in 2006 to $1,562 in 2022. The primary reason for the affordability challenges in employer-sponsored insurance is rising healthcare prices. On average, commercial insurers are paying twice the amount that Medicare pays for the same service. In some markets, 3 times the amount. There are a number of reasons for this. First, consolidation in the healthcare sector is granting providers with outsized market power to demand higher reimbursement rates. Second, a lack of price transparency has left many employers in the dark about what is driving cost growth. Third, many of the third-party vendors and brokers that employers use to shape and administer their health plans have financial incentives to keep healthcare costs high. Employers cannot solve the affordability crisis in healthcare alone. They need support from policymakers. Unfortunately, 3 of the 4 concepts under consideration today do not address the cost drivers in our system. They simply shift the burden of cost growth to employers with older or less healthy workforces. First, association health plans. The primary way that AHPs offer lower premium rates is through the exemption from ACA rating regulations. This enables them to cherry-pick healthy employer groups out of the ACA-regulated market. AHPs just create new winners and losers, with the losers being those who are older and sicker. Second, the Self-Insurance Protection Act. This proposal would further encourage the proliferation of level-funded plans in the small group market, posing 2 primary risks. First, many small employers may be exposed to unexpected financial liability when they self-fund their plan. Second, if small employers with younger, healthier employees shift to the level-funded products in significant numbers, it leaves employers with older and sicker workers behind. This causes adverse selection, where premium rates rise for employers whose groups cannot pass the stop-loss issuer's underwriting. Just as with AHPs, this legislation does nothing to address the underlying reason why there is an affordability crisis for ESI: the prices that commercial insurers pay for provider services and prescription drugs. Third, the Telehealth Benefit Expansion for Workers Act. Let's be clear, there is nothing in federal law today that prevents employer group health plans from covering telehealth services. Indeed, 96% of large firms already do so. Employers are struggling to afford the rising cost of healthcare. This is indisputable. But encouraging the proliferation of stripped-down telehealth benefits in lieu of a group health plan will discourage care coordination. They do not cover basic things like hospitalization, prescription drugs, and labs, and they do not have to comply with consumer protections or mental health parity. Lastly, I want to thank the subcommittee for attempting to roll back a hospital billing practice that is driving up costs for employers and enrollees alike. The facility fee proposal before this subcommittee is a step in the right direction. Thank you for your time, and I welcome your questions.
Thank you, Mr. Corlett. And finally, we'll recognize our fourth witness, Mr. White.
Thank you, Chairman Good. And there.
Are you on? Your mic on?
There we go. How's that? Thank you, Chairman Good and Ranking Member DeSaulnier, for inviting me here to testify on the ways to reduce healthcare costs for working Americans and their families. My name is Joel White. I'm the president of the Council for Affordable Health Coverage. We are a coalition effort with a single focus of reducing healthcare costs for all Americans. And while I address specific issues in my written testimony around association health plans and self-funded arrangements, I'd like to spend a few moments on the bigger picture. I think we need to end policies that drive up costs for employers and enact reforms that drive down costs for working Americans. In my mind, this is the most important issue since most people, about 160 million Americans, get their coverage through their job. This is more than the total enrollment of Medicare, Medicaid, and Obamacare combined. And workers like their benefits a lot. They want to keep their coverage and they want to improve it, not replace it with a government-run healthcare program. I think this issue is also important because businesses and their employees can no longer shoulder the burden of skyrocketing costs. The average cost of a family plan today is about $22,000. Costs have increased 288% over the last 20 years, consistently outpacing wages and inflation, making health coverage less affordable. That is not sustainable. I don't think it's any secret that the path to single-payer health care runs through the small group market, and 90 million workers in small businesses are a soft target. Under the Affordable Care Act, mom and pops are burdened by costly health care taxes and regulations that don't apply to large group plans. Only 1/3 of small businesses can even offer to provide coverage. Those that decide to offer a company plan must then face unfair competition from the government. They can't compete with zero-premium Obamacare and Medicaid plans bankrolled by U.S. taxpayers. Subsequent regulations have weakened the employer firewall, and rich subsidies have lured healthy workers into free coverage. This is a classic predatory pricing scheme. It makes it unrealistic for paycheck-to-paycheck workers to choose private coverage even when premiums are reasonable. According to a recent survey by NFIB, equal numbers of small business owners now get health care through the government as they do through private insurance plans. All told, 12 million small business workers now populate government-run safety net programs. Some would call this a success, but in Obamacare, these workers face deductibles that are twice as high as in the small group market and 3 times higher than the large group plan average. In both Obamacare and Medicaid, patients often struggle to find a doctor who will see them. Millions have a government insurance card but can't access the care they need. This is in fact a disaster for those who support lower cost private coverage and want to preserve government safety net programs for the truly needy. Polls consistently show that what voters want in most healthcare is affordable employer benefits. They want more coverage options, and they want their insurance to work better, meaning lower out-of-pocket costs and better access to doctors and drugs. Congress should remove barriers that make it harder to get coverage at work. There are 3 things you can do. First, expand choices for employers and their employees. Second, provide financial incentives to ensure employer coverage remains viable. And third, enact policies that lower the cost of health services and drugs. In terms of the first bucket, Congress should enact legislation to create new association health plans, which allow more employers to band together to pool risk and get a better deal. This could reduce premiums by up to 30%. You should also create a level playing field by ensuring small businesses can access the same policies as large businesses, including through self-funded arrangements. Congress should also allow standalone telehealth coverage for workers, a benefit that expires when the public health emergency ends in 2 weeks. To provide financial help, Congress should reform the small business health care tax credit so it's just as easy for mom and pop workers to get coverage from employers as it is in Obamacare and Medicaid. Finally, to lower costs, Congress should end dishonest billing practices that allow hospitals to charge facility fees and higher prices for services delivered in physician offices. These reforms should be bipartisan. When Obamacare passed, its authors took great pains to argue employer coverage would remain intact. What we've seen since is a war on employer coverage. Congress needs to take steps to end that war. Thank you for your time. Look forward to answering your questions.
Thank you, Mr. White. And under Committee Rule 9, we will now question witnesses under the 5-minute rule. I will wait to ask my questions at the end and therefore recognize Mr. Wahlberg from Ohio for 5 minutes.
I'm going to let you do that over, Mr. Chairman. I appreciate your comedy.
Oh, Michigan. Of all things to say, Ohio versus Michigan. Sorry to my early morning workout warrior, Mr. Wahlberg from Michigan.
That's a Buckeye mistake.
We fly over there.
And though I'm glad to see Iowa there, I've got a twin brother living in Iowa. So thank you for allowing me this opportunity. I'd like to thank the chair and our panel of witnesses for joining today's important discussion. An important discussion that has gone on for too long. It needs to come to a solution that I think will work, and I think we're talking about that today. The high cost of health care remains a struggle for small businesses, many of whom are facing lingering hardships from the pandemic as well as inflation, which is a tax on everyone. Association health plans are a common sense solution that empower small employers and their employees when making health coverage decisions by providing small businesses with greater bargaining power. It allows them to offer more quality options for workers at a better price, and that's what we're looking for. The association health plans will expand pathways to more affordable health care for small businesses and entrepreneurs across the country. The other bill that I'm pleased we're discussing is H.R. 824, the Bipartisan Telehealth Benefit Expansion Act, which continues employers' ability to offer standalone telehealth benefits to their employees, especially part-time and seasonal employees who would not otherwise be enrolled in the employer's medical plan. Telehealth was a lifeline for millions during the pandemic and has the potential to alleviate provider shortages, especially in mental health and behavioral health. Last Congress, I was proud to partner with my friend, the late Jackie Walorski, as she spearheaded congressional efforts to expand telehealth. I'm honored to take up this bipartisan bill with Representatives Del Bean, Alan, Craig, Estes, and Cheryl, and hope we can advance this bill in Jackie's memory and for the benefit of needs out there in the community. Ms. Strauss, large businesses can offer lower cost plans to their employees because their size allows it, and they enjoy economics of scale, administrative efficiencies, and negotiation clout. In your experience, how would expanding association health plans for employers level the playing field for small and mid-sized employers and lower costs?
Yeah, well, I think we can all agree options are great. So the more we can put on the table for employers to actually be able to access is a good starting point. In the association plan space, the large employers have the ability to build based on the number of lives they have, the risk that they can spread across that. When you look at association health plans, this has that same idea behind it. Once you get into that larger space, you actually have more access to carriers, you have more access to plans, you have more flexibility with customizing those benefits for your employees. And so that's just one big thing for us, looking at how out-of-pocket maximums have been going just through the roof. I mean, right now the average out-of-pocket maximum is $9,000. So that is not sustainable. So when we look at the association health plans with specific guardrails, which I think have been outlined in this bill, it gives those employers the ability to actually feel like a large employer, but then each employer is actually looked at within their own risk. So in the situation where maybe you do have an older population, or you might have some people that have some health issues, you still have that big, large pool that is helping that situation. And so you still have that risk that's being spread apart, but then those employers are still specifically looked at on their own. So they could have a rate.
Safety and security and flexibility with that as well.
Absolutely.
Yeah.
And what we do see in these types of benefits are more robust benefits. So, yeah.
Thank you.
Yep.
Mr. White, Ms. Corlett's testimony alleges that association health plans may offer low so-called teaser premium rates to cherry-pick health employer groups. Does the Association Health Plans Act allow for teaser premium rates?
It does not. In fact, it sets a rate for the entire group, and if there was a teaser rate offered, that would be considered not actuarially sound, which the bill actually requires. So teaser rates are not authorized by this bill.
And we don't want to tease. We want the experience to be
tease.
good and productive.
That's right.
Let me move over to the telehealth benefits. Mr. Watts, Ms. Watts, excuse me, Mrs. Watts, what type of employers currently offer standalone telehealth benefits?
Sorry. I have a couple of examples of our clients that do this. One is a national convenience store chain that's very similar to the restaurant chain that I mentioned, a private daycare preschool employer and a K through 12 employer who need teachers in the classrooms, and they just want to be able to continue, doing business and providing something that's valuable, and they have very low take-up rate of their insurance, and so it's super valuable. But then we've got like a smaller landscaping company. It's kind of a transient workforce, lower paid, and they just feel like they needed to do something, and so it was a way to provide that care.
Better health, better opportunity. My time has expired, and I'll submit further questions for the record. Thank you.
Thank you, Mr. Wahlberg from Michigan. And we will now recognize our ranking member, Mr. DeSaulnay, for 5 minutes.
Thank you, Mr. Chairman. Well, again, thank you for having this meeting. As I mentioned in my introductory comments, I'm a former small business owner, having owned restaurants in California, including places like San Francisco and Berkeley, California. So you can imagine, looking at my colleagues, sometimes that, from perspective, might have been a challenge. I was successful at it. But I was also a longtime member of the NFIB, although I think when I was in the legislature, you might have terminated my membership. I was also a member of the California Restaurant Association. So, Ms. Corlett, as a small business owner, I can see the benefit of banding together for small business. I agree with much of the comments, but getting it right to make it work for everybody, and human nature being what it is, a lot of the proposals allow for people to manipulate what should be a benefit for everybody. So could you comment a little bit about how we could get association and pooling together, like people like the California Restaurant Association for small members, to get the benefit that large employers get under the ACA?
Thank you, Congressman. And first of all, I want to say that I think the chairman and the other witnesses that I'm here with, we are all, I think, equally concerned about the burden of healthcare costs for small businesses. They really are hindering competitiveness and threatening the financial success of small businesses. With respect to association health plans, the concern that I and many have is that they offer lower premium rates to small groups when they are permitted to adjust rates based on each small employer's health status or age. And if they don't have to participate in the Affordable Care Act single risk pool or risk adjustment programs. This means that they can use underwriting practices to skim off the healthier small employer groups, and they can offer a lower rate because they're paying less in healthcare services because it's healthier groups, leaving in the ACA market small employers who have older workforces or who have workers who are not as healthy. So this leads to what we call an adverse selection problem in health insurance, which means that premiums start to go up and up for those employers who aren't as healthy as the ones attracted to the AHP.
And that was the case, but worse before the ACA, particularly in the restaurant business, because younger employees, and I was one once, when they first start many times when they're still going to school, don't want to pay for health care. I had young employees who said, well, why do I have to pay anything? And you only pay a portion of it. I'd prefer just to get a wage increase. So the ACA is trying to address that. And I wouldn't say it's a finished product by any stretch of the imagination, so hopefully we can work on it together. Let's talk about telehealth. First, on the medical side. Now, as a survivor of stage 4 cancer and a consumer continuing with an immune system that needs constant attention, telehealth can be a benefit. And I agree, particularly in rural areas, multiple benefits. So again, getting it right and having a rational, less ideological conversation. As a survivor of cancer, I don't care what registration or ideology my doctor is, as long as he keeps me alive. So here's an example where I think we could work in good faith, acknowledging we start at different perspectives. Tell me about some of the pitfalls as you see it, as you've already explained in the beginning, particularly about being transparent, so people understand that telehealth, it could be a component in medical health. And then maybe you could add a few comments about on the behavioral health side, again, where I could see a great benefit and have seen personally a great benefit.
Sure, absolutely. Well, it's very clear that employers and employees highly value the delivery of healthcare services through telehealth. As I mentioned in my statement, 96% of large employers already offer some coverage of telehealth, and a vast majority of them think that the use of telehealth by their employees is likely to increase over time. So employers are committed to covering telehealth services, and they see it as a really important part of their employees' health benefits. My concern with creating a telehealth benefit as a quote-unquote accepted benefit under ERISA is that it carves it out from the employee health plan, siloing it from major benefits. It exempts it from all federal regulations, including mental health parity, Affordable Care Act protections, and so it leaves people without those protections. We've also seen with other accepted benefits, such as fixed indemnity, that quite often these benefits are marketed to consumers in deceptive and misleading ways, leading them to believe that they are getting comprehensive health insurance when they're actually getting a product that does not provide financial protection.
Thank you. My time is up. Mr. Chairman, I look forward to working with you on these issues, because I hope you can tell from my comments, although I strongly disagree with many of your perspectives, I think there's an opportunity here to accomplish some real good for the American public. Thank you. I yield back.
Thank you, Ranking Member DeSaulnay. And now I recognize Chairman Virginia Fox from North Carolina.
Thank you, Mr. Chairman. And I thank our witnesses for being here today. Mrs. Watts, most Americans who are covered by employer-sponsored insurance are satisfied with their coverage. Yet our Democrat colleagues continue to push the expansion of government-run, one-size-fits-all health care programs. Can you discuss the benefits of employer-sponsored insurance as compared to plans on the Obamacare exchange?
Of course, Chairman Fox, I'd be happy to. First of all, the benefits that are provided by employer-sponsored plans, for the most part, are much better than those on the market. the deductible levels tend to be lower and the out-of-pocket maximums are lower. In addition, the contributions are lower, even with the government subsidies for many people with employer-sponsored health plans. I think one thing, though, that we maybe lose sight of is that the networks that the employer plans use tend to be a broader network of providers, and so it's not a narrow network. It gives members more choice of where they can seek care. One thing that's kind of near and dear to my heart is innovation. Employers are always looking to spend less and do more with their benefit packages, and I think they really push the market and they go after the new up and coming things that are available. They're more quick to adopt those things, and they're not just caught up in a lot of regulatory barriers. And then, I will say that employers work hard to offer, a curated choice. They typically offer 3 or 4 benefit options. There's a lot to choice architecture, and you can overload somebody with choices and it becomes overwhelming and they can't decide what plan they want to be in. And I think the idea of meaningful choice is very important to employers. The last thing I'll say is that we do a survey worldwide of workers, and when we ask them whether or not they agree that their employer cares about their health and well-being, 66% of workers globally say that their employer cares about their health and well-being. In the U.S., it's 75% of workers feel that their employers care about their health and well-being, and I think that that's a big part of why employers offer health care benefits.
That's great news. And your comments mirror my experience in hearing from constituents. They hate Obamacare and the government-run programs because they're not flexible. Mr. White, Ms. Corlett wrote in her testimony that expanding access to association health plans and tools that employers need to self-insure, such as reinsurance, will shift costs to the individual and fully insured market and will result in employers offering worse coverage. And I think we've even heard those comments today. Do you agree? Why or why not?
Yeah, I disagree. I think our first goal should be to expand choices and options for employers, but I think the assumption is that healthy people will be the ones to switch, and that will destabilize both the individual and the large group market. And we just disagree with that. In fact, we think that there's a couple of reasons for that. I think AHPs will actually be a richer set of benefits for people. First, I think they'll have bigger, wider provider networks, more access to doctors and drugs and hospitals. We see very narrow networks on the ACA. The second reason is I think AHPs will provide lower deductibles, and we see very high deductibles in Obamacare. $4,500 is the average in 2021. It's less than twice that in the small group market. So less cost sharing. That will attract people who have some claims experience, that have health conditions, right? So it's not going to be all the healthy people. It'll be a mix of risk, right, which means that that risk will be pooled together. Rates will be driven down because you have a larger risk pool, and people will experience lower premiums. But there's no subsidies in these AHPs or self-funded plans to attract that healthy risk. So a lot of healthy risk will continue to choose Obamacare, where the subsidies are very, very, very generous. Right. So that's most of the reasons.
Thank you very much. Ms. Strauss, do you agree with Ms. Corlett's statement that, quote, many small employers are not sophisticated purchasers of health benefits and may not realize the financial risk and fiduciary duties they take on when they self-fund their plan? Why or why not do you agree?
Well, I would say probably the majority of Americans are not sophisticated buyers of their health insurance. So this is the role of the insurance agent. This is why having an agent is so important today, because we are looking for options across all lines. And in some cases, that is actually using the marketplace as an option for small employers in group products.
Well, let me add to that. I think the left's attitude toward us as individuals and to small business is very negative. They think we're all a bunch of dumb people who don't know how to make decisions for ourselves. That's why you need the government to do everything for us. The Life of Julia shows, government takes care of everything. I think it's a real slam on small businesses My husband and I had a small business. My daughter runs a small business. Every small business person I know is very bright. They couldn't stay in business if they weren't bright and had to figure out how to get things done. And I think this kind of attitude is an attitude that exists among Democrats and the left, and it really is terribly offensive to me. Thank you very much.
Thank you, Chairman Fox. And now I'd like to recognize Congresswoman Wild from Pennsylvania for 5 minutes.
Thank you very much, Mr. Chairman. And let me just start by saying that it always dismays me the amount of vitriol and partisanship that we experience when we're even engaging in discussion and debate about healthcare in America, and it's really a shame. I think the one thing we can probably all agree on is that we are fortunate to have some of the best medical providers and hospitals in the world right here in the United States, and it would be really nice if we could all come together behind making sure that every single American can afford these outstanding providers that they often need but cannot afford. So I would really, one of my major goals in Congress, I will tell you, I've been here since the beginning of 2019. This is my third term. One of my major goals is to try to find paths for bipartisan bills that we can work on that will advance this cause. And so I will be very open to any suggestions that any of the witnesses might have about that. But before I open it up to that, I just want to say that one of the things that I am proud of that we were able to do on a very bipartisan basis in 2020 was to advance legislation to protect consumers from surprise out-of-network bills, and ultimately passing the No Surprises Act. And I personally, in my family, have seen the advantages of that, but I've talked to many others who have. So, Ms. Corlett, let me just start by asking you what your thinking is, what your knowledge is of how the No Surprises Act has made healthcare more affordable for consumers.
Sure, yeah, thank you for the question. So, as you know, the No Surprises Act protects people with insurance in certain situations when they really have no choice of providers. So those are emergency situations, and also if they are getting care at an in-network facility, they've done their homework and they've made sure to go to an in-network hospital, and yet they are treated in some way by an out-of-network clinician. That could be an anesthesiologist or a radiologist
And I'm sure there is no person around who hasn't received a bill at some point in time looking at it saying, I don't know who this doctor is, I don't know when I received this care except for the date on the bill, and that's very frustrating for everybody.
Right, absolutely. So the law went into effect last year, so we're about a year plus into it, and the good news is that it's working as intended. 177 million people now can have peace of mind that if they have an emergency or if they're in a hospital that they know is in network, they are protected from those surprise medical bills. So good
And the
news.
one thing I would note on that is that I believe, if I'm not mistaken, that we still have a lot of problems in terms of people who require ambulance service, EMS not being covered in network, and I've talked to EMS providers in my own district. That's an area that I would personally like to see us move forward in a bipartisan way and try to figure something out. But I'd like to open it up if any of you have any, I wish I had far more than a minute and a half left, because this is a really important topic, but I'd love to hear any ideas that any of you might have for other initiatives that we might take on a bipartisan basis. And I open it up to any one of you.
I'll jump in here. I think that you mentioned one, it's expanding out No Surprises to cover ambulance services, huge out-of-pocket cost for a lot of people who get surprised and not covered by the law, right? Mm-hmm. So that's important. The other thing I would focus on is telehealth. I mean, the telehealth bill that we're discussing today is bipartisan. There are a number of Democrats and Republicans on that. And I think what we saw during COVID was telehealth really filled the gap. It allowed people to access care that they otherwise wouldn't be able to get.
Let me just, I'm sorry to interrupt, but I will tell you, I am a huge fan of telehealth. I actually sponsored a bill during COVID to make sure that older Americans had access to telehealth. I really am a big fan of it. I have a great concern about standalone telehealth plans and whether they would be, that people could be misled into thinking they had a comprehensive health plan, and when they needed a hands-on doctor, they wouldn't have that ability. Okay, with 15 seconds left, go ahead, Ms. I'm sorry, go ahead.
I just want to bring up the fact that the cost controls are a big thing too. So the site neutral payments and facility fees within the hospitals and buying up all of these small little independent providers.
I actually plan to submit a question for the record. I knew that I would run out of time on that very issue. So thank you very much. Thank you all. Thank you for this important hearing.
Thank you, Representative Wild. And now we will go to Congressman Allen from Georgia for 5 minutes.
Well, thank you, Mr. Chairman and Ranking Member. Ranking Member, I miss sitting beside you, by the way. Those were some good hearings we had back in the day. But it's good to be here this morning. And I come from the business world. I was in business. Still, my wife in business now. I tell people all I own is a Tahoe and a member of Congress. But yeah, I served because I was involved in health care. I was chairman of a hospital board for 9 years. I was asked to serve on the Healthy Future Task Force. And I'll tell you, what I learned is this government is driving up the cost of health care because the government is driving health care. Even the private sector has joined forces with the government. They're all in it together. I challenge my colleagues, you talk about anger and vitriol. Go to an emergency room on a Friday or a Saturday night. Get out in your districts, see what's going on. You will see anger and vitriol like you've never seen it before. And I personally feel empathetic to those providers that have to sit there and put up with what these people are throwing at them, and then they have to take care of them. And unfortunately, that's where our country is. In fact, what I found in this process, in talking to, we talked to hundreds and hundreds of professionals, patients, you name it, to try to get to some solution here. Nobody's happy in health care. Nobody. The patients aren't happy. The providers aren't happy. And let me tell you, you talk to the American Medical Association, we are experiencing a severe shortage in providers. That's not going to be good for any of us. And so I ask the question, why? It's because this government is in charge of your health care. We have only a government health care system. That's it. All the privates, all the hospitals have got on board and are following it right down the road. So, like I said, I come from the business world. And what I would like to ask Mr. White is this. Obviously, the only way to bring down costs is competition. Right now, the only people that have a waiver, and our state's been trying to get waivers to drive down costs in our state of Georgia. And we got waivers from the Trump administration, and they were all taken away under the Biden administration. We were driving down cost with these waivers. The only people that get waivers now are unions and the faith-based communities, and thank goodness for the faith-based communities because they have some programs that are reducing costs for families of faith. We have to have a private system in this country to compete with the government system. That will keep government accountable and competitive, because right now it is the wild, wild west, and we're going to, and it's unsustainable. Mr. White, what are your recommendations?
Yeah, I think you highlighted the problem excellently. I think the fallacy is that people think that we have free market health care in the United States. We don't.
No.
We have 93% of all health markets are highly concentrated. That means they lack competition. for services, providers, doctors, hospitals, et cetera. And in those markets, consumers pay much higher prices. And one of the reasons is we have a lack of enforcement from government bureaucrats and agencies. But the other reason is that we really have done a poor job explaining what free market health coverage is. And I think you're starting to take some of those steps here today to talk about competition, letting people band together to get big pools to negotiate lower rates. Look, Costco and Amazon can negotiate a lower price because they're really big.
You give the business community a waiver, they'll fix healthcare in this country. Quality will go up, providers will come back because they don't have to deal with the force of this federal and the oppression of this federal government.
And Congressman, may I say one more thing? 50 cents of every dollar spent in healthcare comes from Washington, D.C.
Yeah.
And every entity in healthcare is regulated at some level, local, state, federal, by regulations. And so they're constrained in what they can do and offer. What we're talking about today is flexing that up just a little bit.
Yeah, and I got to add one thing. I asked the question to every one of these professionals, can you break down the cost of healthcare for me? Peel the onion. That way I can figure out where the money's going. Not a single one of them can do it. And with that, Mr. Chairman, I yield back, and that's the only way we're going to get to the bottom of this, because somebody is on the take here. Thank you.
Thank you, Congressman Allen. And now we will recognize Congressman Courtney from Connecticut for 5 minutes.
Well, thank you, Mr. Chairman, and thank you for the witnesses for being here. I'd like to just start and follow up with some questions with a basic sort of fact, which is that really just months ago, we finally enacted a cap on insulin for Medicare patients. Again, this is a drug that's been off patent for over 100 years. I mean, any sort of argument that it needed to be priced 2 or 3 times higher than what people pay in Europe or other parts of the world, because we got to support our R&D, I mean, is absurd when you talk about a drug like that, which again, it's been off patent. So again, starting in January 1, Medicare patients are now paying no more than $35 a month for their insulin refills. I have friends in my district who that's a 1/3 of what they were paying before. And when we passed the bill initially in the House, it actually extended that benefit to working age individuals in their employer-based plans. We unfortunately came up, I believe it was about 3 votes short in terms of overcoming the 60-vote threshold in the Senate. And to me, that just sort of is blindingly obvious that that is a way of helping reduce the overall, not just that specific drug, but also the overall cost. And frankly, we need to look at that deeper. In Connecticut, we just had approval of small group plans. I think it was about 12.9% in the state of Connecticut Department of Insurance. They identified prescription drug costs as the #1 cost driver in terms of what is making premiums go up. And again, it's not because of the fact that we don't give the government enough authority to negotiate a better price like we did with insulin. It's because we don't do enough of that. And so again, I just would ask Ms. Corlett to just sort of comment on that if we're really serious about reducing costs, we got to look at what insurance plans actually pay for and try and figure out ways to reduce those costs.
Thank you, Congressman, for the question. Yes, the Inflation Reduction Act made great strides in improving prescription drug affordability for Medicare enrollees, but stopped short of extending that help to people with employer-based or commercial insurance. A recent analysis by the Kaiser Family Foundation found that capping insulin at $35 a month for people with private health insurance would provide financial relief to about 20% of employees. And for people who pay currently more than $35 per month for insulin, half of them would save at least $19 a month, and 25% would save at least $42 a month. So really significant savings.
So, it's interesting because we're about to vote, I guess, this week on this debt ceiling plan where huge pieces of the Inflation Reduction Act are being gutted for energy tax credits. It appears that the majority has kind of kept hands off the insulin price. I mean, again, I'm not sure of that for a fact, but we'll maybe find out more. But I mean, to me, that speaks volumes about the fact that that is just an undeniable policy advance in healthcare, which is to use the negotiating authority of Medicare, which is the second largest health plan in our country, to really get a better deal in terms of what the taxpayer has to underwrite as well as what the patient has to pay. So again, the bill goes on, though. It's not just about insulin. It also is going to cap out of pocket for anyone on Part D over a time period. I met with MS patients, multiple sclerosis patients, who are now getting injection treatment where despite the fact that they are affluent, even good insurance, I mean, they are just totally hammered by the cost of that, and most of them end up on Medicaid. They were in tears, the gratitude for the fact that Congress did what we did in the Inflation Reduction Act, which was putting an overall cap, again, that will apply to their predicament. And again, just, if you could, Ms. Curlett, comment on that we're talking about a broader universe of savings.
That's right. I think leveraging the negotiating power of a large purchaser like Medicare to deliver savings to employer-based plans for high-cost prescription drugs will trickle down to savings for workers and their families. And then the other protections in the IRA, particularly related to that cap on out-of-pocket, would also be incredibly helpful for a lot of families. Thank you.
Thank you, Mr. Courtney. And now we will recognize for 5 minutes Congressman Banks from Indiana.
Thank you, Mr. Chairman. There are nearly 500,000 small businesses in Indiana that employ over 1.2 million Hoosiers. Ms. Strauss, you wrote that 98% of small businesses report that healthcare costs will become unsustainable in the next 10 years, threatening their ability to survive and remain competitive. And I wonder if you could just be more specific and explain to us what are some of those main drivers of those costs that you're talking about?
Yeah, thank you for that question. And I am going to continue on that pharmacy topic that we just opened up. And I love the starting point of addressing some of these insulin prices. But when you negotiate on Medicare only, most of the time, those drug manufacturers actually move those prices somewhere else. It gets moved into the private market. And so that becomes challenging. Right now, 25% of premiums are driven by your prescription costs. And caps, again, sound lovely. But why are we not going to the drug manufacturers and making sure that those insulin prices are affordable for everyone across the board? So those are the conversations that need to be had, and if we don't address those, then that right there is a huge factor. Our specialty medications are driving the majority of our claims that are coming in, and most of those people are seeing commercials on TV and they're walking into their provider's office and asking for those specific medications. I have an employer right now that 91% of their prescription costs are driven by 10 specialty medications. It's a huge spend for them. So I would say that is first and foremost. And then the hospital site neutrality payments. We love our providers. We have to have them. We live in a very rural state, and it is super important to make sure that doors are open. After the ACA rolled out, there was a ton of consolidation, and so we saw a lot of private individual practices move into that hospital system. Our doctors have lost the ability to care for their patients the way that they went to school and the reasons that they went to school. So we need to make sure that everybody is taken care of, and that when people are going in to have a test within the same system, that test costs the same regardless if you're in small town Iowa or if you're in Des Moines at a hospital system. So those are two things that I think are driving the costs that I believe that Congress can actually do something about. And, really just more access and options, getting association health plans out there, having that ability for employers to make choices for themselves and for their employees.
So your state is a lot like my state, and maybe expand on that a little bit. Talk about how do we get to this point where small businesses feel like they might not be able to provide the same level of quality healthcare options for their employees as what they used to. I mean, it seems like that's devastating to the families who you put to work, and with good paying jobs. It seems like that would be very disruptive
Yeah.
to your ability to do business. So how did we get to that point?
So in Iowa specifically, when before the ACA rolled out, we actually had protections across the board for everyone, regardless if they had pre-existing conditions, and specifically in the employer market. So when you came in as a new eligible employee into an employer group plan, they did not have pre-existing limitations on those plans. If you were somebody who chose not to enroll and a year later decided to enroll, there could have been limitations based on that, but we had a high-risk pool in Iowa that accepted everyone that got denied coverage. So we had safety nets in place to actually make sure every single Iowan had access to care. In that high-risk pool, we had $500 deductibles. Those are unheard of in Iowa today. So we also saw the age-rated band, the age bands come out, and that created, first of all, our older population paid more, but it did not offset the younger population. Their rates also went up, where it was on average, you could have a young 20, something, their premium could have been $125 on average. Those premiums went up over $300. That is why those young, healthy people did not enroll in those marketplaces. And so when we start to get that, where everything is just driven by claims and we don't have prevention on the front end of things, that is what's driving up costs. That's what's making it unsustainable for employers today.
Well, I appreciate you sharing your unique perspective. Small businesses are the backbone of our economy in states like Indiana and Iowa and throughout the country. And it's my sense that members of Congress should be listening to people like you a lot more than what they do. So thank you. I yield back.
Thank you.
Thank you, Congressman Banks. And now I would like to recognize for 5 minutes Congressman Norcross from New Jersey.
Thank you. At this point, I'd like to yield 1 minute to my colleague.
Just really quickly, Ms. Strauss, I just want to reiterate the point that I made, which is when the Inflation Reduction Act came out of the House, that insulin piece was not limited to Medicare. It was extended to, we amended ERISA to make sure that it would be extended to employer-based plans as well. Unfortunately, Senator McConnell whipped a no vote on that, and that provision was stripped because it was ruled by the parliamentarian not to be budget related. It was a policy issue. The good news is that Susan Collins and Patty Murray are on a bipartisan basis going to be introducing a bill to do exactly what you just described and which we supported already. And hopefully we can all have a nice bipartisan kumbaya and come together and realize that those savings for insulin should be extended to working age Americans through their employer-based plans. And I would now yield back to Mr. Norcross.
Thank you. Appreciate it. I see the actual hearing note says reducing healthcare costs for working Americans and their family. We can do that very easily by just cutting coverage. Obviously, any healthcare has to be comprehensive coverage and quality coverage. And coming out of the pandemic, we've seen just the massive impact that COVID has had on the average American, both physical and mental health. And the question I want to get to is the mental health piece of this. Last year, the Department of Labor did a study to find widespread violations of the Mental Health Parity and Addiction Equality Act. In the report, the department recommends Congress provide additional tools to improve enforcement, including granting the Department of Labor the authority to issue civil monetary penalties for violation. Next month, I plan on reintroducing the Parity Enforcement Act. When we look at what is in place now, the law says one thing, but without any meaningful employment, it's literally like having no police on the road and people will just drive whatever they want to do. And certainly we see what happens when that doesn't work. The violations come flying in. Ms. Corlett, what are some of the barriers to making the promise of the Parity Act an actual reality? And how could we improve the enforcement and making sure that this care is available to all Americans?
Thank you, Congressman. So, as you said, enforcement of MAPIA is absolutely critical. When the Department of Labor recently asked group plans and insurers to share their analyses of how they were covering behavioral versus medical health services, not a single plan was able to submit documentation to enable Department of Labor to even assess what they were doing. It's a clear sign that plans and issuers may not be taking their compliance obligations seriously enough. MAPIA was enacted in 2008. We're 15 years into this. So civil monetary penalties certainly could help send a strong message that access to mental health services is really vital for workers and families. I think it could also be helpful for the Department of Labor to provide some guidance and more clarity to plans and issuers about what those obligations are. But knowing that there is a cop on the street is absolutely critical.
Again, right now, if there's violation, if they get caught, they just pay for it. Obviously, from the bottom line, financially, we tried to allow the market, the free market, to go and take care of this. Again, your point, 15 years, it's not being done. So I think this is incredibly important. I think everybody on this panel, both sides of the aisle, understand mental health is a real issue. The addictions, the list goes on. The idea that we're allowing part of the free market to just go and do what they want, and we see the violations, is exactly why I think we should talk about implementing this and moving this forward. With that, Chairman, I yield back.
Thank you, Mr. Norcross. And now I'd like to recognize Representative Smucker from Pennsylvania for 5 minutes.
Thank you, Mr. Chairman. This is a great discussion this morning. I'd like to thank the chairman for scheduling this hearing, thank the witnesses for being here. And I'd like to thank the ranking member and other members from the other side of the aisle for some of the comments that they've made in regards to the common ground that we have on these issues. I think we're all interested in ensuring that every American can access the great health care system that we have here. We have differences about how we can best deliver that, but we have great discussions here today about potential solutions. And I'll use the term that the Democrats are often fond of, universal health care. I'd like to see universal health care. To me, that means that everyone can manage their health care expenses by having access to insurance if they want that access to insurance, and hopefully at a price that they can afford. We believe it can best be done by competition among providers and competition among hospitals, competition among insurers, and we think a system with that in place will deliver the best chance of ensuring that access. I ran about a 200-employee construction company, self-insured, and you've all talked about the benefits of self-insured, some of the problems with the red tape around that, the flexibility that can provide. And so I just want to mention the benefit that I saw of also creating partnerships between employers and employees to improve health care or improve health of employees and reduce costs. There was a shared risk in that. And then I've seen telehealth in my district. I've heard some of the concerns about telehealth, and it's the first I heard some of them, because I've always seen telehealth as being sort of better access to health care, part of a larger system, and literally helped to improve outcomes because patients tended to go to a doctor sooner and maybe take care of a health problem before it became larger. But I've also seen, and I want to ask this question, maybe Mr. White, I'll ask you, we have some very innovative systems by employers in my area where telehealth is part of it, but also then direct primary care. And this is where there's a sort of a monthly fee to a doctor that is then on call for employees. And even groups of employers are doing this at times. And people love it because they can call, rather than missing work, having to go a distance, they can do telehealth, and then sometimes the direct care provider will even be on site if it's a large enough company. I have a bill that would help to, introduce it with Mr. Blumenauer, Democrat from Oregon, but essentially would ensure that employers who have access to direct primary care would also have access to HSAs, and they would be covered in HSAs. So Mr. White, are you familiar with that? And do you like it? And if so, how could we expand direct primary care?
It's a great idea. I love it. I think it expands options for workers to be able to access care on demand. It's kind of like the old concept when the doctor would come to your home, right? And you'd kind of,
It's like a family doctor.
Family doctor, and you'd get like their attention and their time, and that's what direct primary care seeks to offer is that direct attention, that direct time dedicated to that worker so that they have good access to care. I think coupling it with HSAs makes a lot of sense so that people can pay any of their cost-sharing obligations. And then on the telehealth side, I think one of the things that we've seen during the pandemic is really a focus on behavioral and mental health issues. And really,
Absolutely.
90% of those claims on telehealth.
I want to get to one additional question, and I'm really sorry to cut you off, but Ms. Strauss, you'd mentioned site neutrality payments. And I've heard from this on sort of both sides of the issue, if you will, independent practices who literally have gone out of business because they've been bought up by hospitals that then could charge higher prices. And it's it's a system that we have in place that I think encourages that kind of consolidation, which I think then reduces competition. On the other hand, I have great hospitals in my area who argue that they face unique circumstances that justify the increased price of services. And I'd just like you to address that. Like, how do you talk about that? How do you respond to hospitals that are arguing that those higher prices are justified?
Yeah, and I'm definitely not arguing that they're not seeing increased prices. Everyone in the country is experiencing increased prices across the board. So I think what we want to get to is an easier, more transparent system so that if you are having a lab test in one clinic and the same exact lab test maybe at a different facility, that it should be the same price. We had a member that came forward in Indiana, and he and his wife both had exactly the same lab test. One had it at a clinic, one had it more through a hospital setting. His was $900, hers was $90. So we need to make sure that we know that the price is the price. That type of a thing should not be different. Where we're also seeing some challenges are those facility fees. So in some of those smaller clinics, now we're starting to see a facility fee be added on top of services that really there should not be a facility fee charged on. So we recognize our hospitals are also struggling. We are doing everything we can in the state of Iowa to make sure that all of our rural hospitals are getting what they need. Another piece of that is the Medicaid and the Medicare market. The reimbursements are not great, and so the private market literally holds them up. And so I've actually had a client who's a mental health provider, and she was contemplating lowering the amount of patients she was seeing in Medicare and Medicaid just to keep their doors open, and it was a heart-wrenching situation for her. So reimbursements across the board, we need to get that figured out so that it's fair for everybody.
Thank you. Thank you, Mr. Chairman.
Thank you, Congressman Smucker. And now I'd like to recognize Representative Hayes from Connecticut for 5 minutes.
Thank you very much. The Affordable Care Act dramatically expanded the affordability of health care for millions of Americans. As of January 2023, a record 16.3 million people were insured under the ACA. Additionally, last Congress, Democrats took bold action to reduce prescription costs by passing the Inflation Reduction Act, which grants the HHS Secretary the authority to negotiate the price of prescription drugs covered by Medicare and caps out-of-pocket costs for insulin at $35 per month for Medicare beneficiaries. I have to stress once again that we tried to expand this beyond Medicare, and we were stopped by Republicans. I was particularly disappointed that we would not be covering children with type 1 diabetes, so it is something that we will continue to work towards. And while we have accomplished so much, there are still changes that must be made to make our healthcare system better. Currently, most insurance covers individuals from the neck down. Dental and vision health, which are critical components of overall health, are not covered. Basic insurance health plans rarely cover routine eye exams, regular visits to the dentist, or even extended mental health services. People without access to dental care are more likely to suffer from chronic conditions, such as heart disease, diabetes, and cancer. In 2023, there have already been 55,000 new cases of oral cavity cancers in the United States. Similarly, improving access to eye care allows health professionals to identify and treat problems before they become more seriously, and vision screenings improve academic outcomes for kids. So if we are having a conversation about reducing healthcare costs, it should also be about full and total healthcare. Ms. Corlett, how did the ACA improve dental and vision access, especially for children? And can you elaborate on the remaining barriers to affordable dental and vision care that we are currently facing?
Thank you, Congresswoman, for the question. Sure. So one of the key things that the Affordable Care Act did was establish a set of minimum essential health benefits, which included pediatric dental and vision care. So for the first time, there was a minimum floor that all small group and individual market health plans had to satisfy. In terms of remaining barriers, I would say number one, there are 10 states that have still not expanded Medicaid under the Affordable Care Act. And that places about 1.9 million people in something called the Medicaid gap. They're too poor for marketplace subsidies, but to have too high of an income to qualify for their state's very, very low eligibility. The second thing I would point out is that in the employer market, dental and vision are sort of the traditional examples of accepted benefits. And what has happened with these accepted benefits is they end up being siloed. They're separated from the general comprehensive major medical benefit that we all have. And so, and not only are they siloed out from the rest of your body, which is not logical, the benefits don't tend to be very good. They don't provide a lot of financial protection. The medical loss ratios are quite low. So I just point that out in part because before you today is this proposal to create telehealth as an accepted benefit, which I worry would lead you down the same path where the services are siloed from your regular health care and aren't very comprehensive.
Thank you. And to your point, I would argue that we need to make sure that it is more competitive so that people cannot charge whatever they want, to your point, $90 or $900 for the same benefits. In my state of Connecticut, 531,000 adults have a mental health condition, and many go without the necessary care or services to address their illness. Unfortunately, this reality is felt nationwide as half of adults with mental health do not receive treatment. We're facing a crisis. Ms. Corlett, how can Congress expand access to mental health care services to those who are in need under the ACA and job-based plans?
Well, one thing your colleague mentioned earlier was enforcement. And that's an area where there clearly needs to be more authority and more resources for ensuring that plans are complying with mental health parity. And then just the last remaining seconds, I think workforce issues are really critical. And my colleague here mentioned the reimbursement issues in particular and making sure that there's reimbursement parity for those mental health services.
Thank you. Mr. Chair, I yield back.
Thank you, Representative Hayes. And now I'd like to recognize for 5 minutes Congressman Burleson from Missouri.
Thank you, Mr. Chairman. I worked in healthcare IT for 20 years, and I have seen where the bodies are buried. I've seen the good, the bad, and the ugly, but I've came to this conclusion that the more that this place touches healthcare, the worse it gets. And so some of my questions and my thoughts are the only thing that's going to save the healthcare system is innovation and disruptive innovation. So I'm going to gear my questions in that regard. I think telehealth is old technology, but at least it's here, and at least we have that. So Mrs. Watts, can you talk about the impact of the pandemic and how that has ushered in more telehealth, finally gotten some level of adoption that really was resisted for quite some time?
The great thing about telehealth during the pandemic was that people that had never tried it before and tried it, when we surveyed and said, will you do this again? They said yes. I mean, resoundingly, they said yes. And so I think it was a great way to try it out. But I also think did a huge service to healthcare providers in this country because it kept people out of the doctor's offices and going to the hospitals, and it was a way to triage. And so it was really, kind of a godsend that we even had that as a resource for people to access to determine whether or not their symptoms were related to the pandemic, to COVID, or something else.
And in addition, it gives access to patients who might be in a rural healthcare setting that have very difficult times getting an appointment with a psychiatrist or some of these specialists. So that's a huge added benefit as well. Can you elaborate or give us an idea, what is holding this back? What kind of structural issues are throwing water on this innovation?
Oh, I think that virtual healthcare, digital healthcare are all very fast-growing segments of the market. And part of that is driven by the fact that there is a shortage of providers and people aren't able to get an appointment. And so access to virtual digital care definitely helps. But the other thing that's so important related to behavioral health is that it has really helped us address a health equity issue with access to behavioral health, in seeing low income and minorities be able to access care that they really didn't have access to before.
Let me ask this, and this may be a question for Mr. White. Do we have an issue with, I know state after state, they implement licensing laws. A lot of it is turf issues. Do we have, as a nation, as we approach this increased demand for professionals and people to get access to care, whether virtually or in person, what is the impact of these restrictive licensing laws where they stop potentially mid-level providers from practicing to the fullest extent of their education?
Yeah, great question. And maybe to answer your last question, I think what we saw during COVID was the public health emergency was declared and the government flexed up all the rules. And what did we see? We saw innovation come into the marketplace, right? We deployed and empowered pharmacists to deliver care to patients, to fill gaps in access, which is a really critically important strategy. 250 million vaccinations through the pharmacy channel as a result of some of those policies. But also tests, being able to deploy prescriptions for people who are sick, et cetera. We saw telehealth, which was a massive gap filler once those rules came off, and care at home. Right? We do a lot of care in very expensive settings that we could actually deliver in the home now based on new technologies and strategies. So with the licensure issues, I think what we've seen is we essentially have a really maybe a 15th century guild system, like with blacksmiths and, and not to denigrate medical professionals, they work hard and get licensed and do their things. But what I think we realized during COVID was you can deploy these mid-level or more junior-level medical professionals to deliver.
Right, and my time is getting close, so I want to move quickly into this. I think it's my opinion that AI is going to could radically change healthcare to the point where it empowers someone who is a mid-level to be more of an expert in diagnosing, more accurate, provide better healthcare standards than our the best medical professionals we have today. Could you elaborate?
And will lower costs. I was in Iowa last year where you've got ophthalmology techs using AI to detect diabetic retinopathy and screen out the people who don't need the surgery.
Yeah,
they're just techs, right? So we have a massive shortage of diabetic techs in this country. You plug the machine in, you run them through the tech, and they get the people who really are going to need the more hands-on care from the physician. It works beautifully, it lowers costs, and it gets people the access they need.
Thank you.
Thank you, Mr. Burleson. And now I'd like to recognize Representative Jayapal from Washington for 5 minutes.
Thank you, Mr. Chairman. For decades, Democrats have proposed and enacted many policies to lower health care costs, which included the passage of the Affordable Care Act. We protected those with pre-existing conditions. We lowered out-of-pocket costs. I've also pushed for policies that expand Medicare, ensure home care for our most vulnerable, and eliminate the many fees and copays charged by private insurance companies. In contrast, Republicans have fought to repeal the savings from the ACA And they continue to propose policies that actually increase healthcare costs for people across the country. Ms. Corlett, I'm going to ask you just a series of questions about Republican policy proposals. You can just answer with a short yes or no on whether these policy proposals would increase healthcare costs for Americans. So the first one is the Republican proposal to take Medicaid away from up to 10 million people by instituting onerous and unnecessary work requirements, as Speaker McCarthy proposed in his debt limit bill last week. Would that decrease healthcare costs for Americans?
No.
And what about repealing the prescription drug provisions in the Inflation Reduction Act, including repealing the cap on out-of-pocket prescription expenses for Medicare? Would that reduce healthcare costs for Americans?
No, ma'am.
How about cutting funding for the Children's Health Insurance Program by billions as proposed by President Trump? Would that reduce healthcare costs for Americans?
No, ma'am.
And what about encouraging the formation of association health plans, also called junk health plans, with no additional regulation? Would that reduce costs for average Americans?
No.
So let's do the same thing with the policies that Democrats have proposed, and you tell me if these would reduce healthcare costs for Americans. Capping the out-of-pocket cost for insulin at $35 per month for Medicare beneficiaries. Would that reduce costs?
Yes.
And how about capping out-of-pocket spending on prescription drugs at $2,000 per year for Medicare beneficiaries?
Yes.
How about extending enhanced ACA premium tax credits, which save my constituents an average of $1,200 per year? Would that has that reduced costs for Americans across the country?
Yes.
So finally, I just want to ask you the same thing about policies that are proposed by Democrats that Republicans have blocked. All those ones I mentioned were things that we already passed. But these are things that have been blocked by Republicans, and you tell me if these would decrease healthcare costs for people. Extending the cap on insulin costs at $35 per month to all types of insurance was blocked on the Senate floor by Republicans. Would that have decreased costs for the American people?
For diabetics, absolutely would decrease costs.
And how about closing the Medicaid gap to cover over 2 million people in the 10 states that haven't expanded Medicaid under the ACA? Would that reduce costs for people in those states?
Absolutely, yes.
So I think I wanted to ask you those questions because I want to be clear about the stark contrast in how our two sides are approaching healthcare, which should be a universal and bipartisan effort to reduce costs for our constituents. But I think that this hearing makes it crystal clear that the Republican healthcare policy proposals are actually increasing costs for people. Democrats have taken historic steps to decrease healthcare costs for Americans. We've allowed Medicare to negotiate with greedy pharmaceutical companies. We've capped the cost of insulin and other prescription drugs for people on Medicare and provided support to families struggling with the high cost of health insurance premiums. We did all of that without a single Republican vote, and we have more to do. I have great proposals to address some of the issues that Ms. Hayes raised around expanding Medicare to cover dental, vision, and hearing, providing all kinds of care that people need, because if our healthcare system can function so that we keep people healthy and we don't put barriers in their way to seeking healthcare, and particularly the equity concerns that we see in our healthcare system with people not being able to access care, particularly Black, Brown, Indigenous folks, particularly poor people, particularly people in rural areas, this country would be much better off. I thank you and I yield back.
Thank you.
Thank you, Representative Jayapal. And now we're going to continue with the minority party since we don't have anyone here for the majority. So we recognize now Representative McBath from Georgia for 5 minutes.
Thank you so much, Chairman Good, Ranking Member DeSaulnier, for hosting today's hearing, and to our guests for taking the time to be with us today. I am a two-time breast cancer survivor and the daughter of 2 healthcare professionals, so this issue today is very, very personal to me. It's personal to me like it's personal for the mothers and children who live in the 50-plus counties in Georgia who don't have a pediatrician or even an OBGYN. It's personal to me like it is for those in my state who are forced to take unpaid time off from work that they can't that they can't simply afford. And they're driving hours away to get themselves or their children the care that they need. While our governor in the state of Georgia knowingly leaves billions of dollars, federal dollars, on the table and refuses to expand Medicaid. There is no justifiable reason why, in the greatest country in the world, that medical bills are the #1 cause of personal bankruptcy. There's no reason why the zip code or the country that you were born into should add or subtract another 10 years from your life expectancy. But that is the reality in America every single day. Republicans love to talk about the high cost of health care after the passage of the ACA, but they fail to recognize exactly how much higher these costs would be for working families without these critical protections and these critical programs. Thanks to President Biden, congressional Democrats, and the Inflation Reduction Act, the number of Americans without health insurance is down to the lowest level in the history of this country. Thanks to the IRA, Medicare is finally able to negotiate with drug companies on behalf of American seniors and ensure that they aren't paying more than they need to for prescriptions like insulin. And yes, that was my law, the reducing the cost of insulin to $35 out of pocket. These protections would have gone even further to support working families by capping the price of insulin at $35 a month for private insurance as well as Medicare. But Republicans successfully stripped this provision from my bill, the final version of the NRA that was actually signed into law. When insulin for human consumption was first discovered and synthesized by Dr. Banting and his team in the it was in the 20th century, they sold the patent to the University of Toronto for $1, just $1, claiming that, and I quote, "insulin does not belong to us, it belongs to the world," end quote. I think that it's obvious that Dr. Banting and his team would be deeply disturbed by the exorbitant price that insulin is regularly sold in the United States today. And it's up to Congress to right this historic wrong. Despite a production cost between $2 and $4 per vial, 1 in 4 Americans who rely on insulin every single day of their lives has had to risk getting seriously ill and cut back or skip their dosages altogether because of the price of insulin. Because of the IRA, out-of-pocket costs for people on Medicare are now capped at $35 a month, and many states have taken similar action, as well as the drug manufacturers, 3 major drug manufacturers. But Congress has to do more to ensure that everyone who needs insulin can afford it, not just those on Medicare. I'm very proud to be a co-leader of the Affordable Insulin Act now, which would extend the $35 cap to people with private health coverage. Ms. Corlett, why is it necessary that Congress pass additional legislation such as this to help cut the cost of insulin, particularly for people with ERISA-covered plans?
Oh, thank you for the question. So the Inflation Reduction Act took tremendous strides to improve the affordability for insulin and for many drugs for Medicare beneficiaries, but it left, as you said, unfinished business. And so addressing the costs of insulin and other prescription drugs for people in commercial or ESI insurance is critical. And as I mentioned, there was a really helpful KFF study that found that a $35 per month cap on prescription drug cost sharing would provide financial relief to about 20% of the 160 million people who are now covered in ESI. So it's really a tremendous benefit.
Thank you so much, and I yield.
Thank you very much. And now we will recognize Congressman Omar from Minnesota for 5 minutes.
Thank you. It's pretty clear from the conversation that Representative Beth was just having and Representative Jayapal that Democrats have spent significant amount of time thinking about and working on policies that reduce healthcare costs for Americans because our constituents are deeply worried about this. Ms. Corlett, in your written testimony, you referenced 2022 CPO that recommended 3 policy interventions on how to constrain healthcare costs. Regulating healthcare prices, reducing consolidation and anti-competitive behavior, and improving price transparency. You also pointed to the Bipartisan Policy Center report that made recommendations that further 7 interventions, such as capping hospital prices in highly concentrated markets. So there are a lot of proposals that are out there and interventions that are available to us. Can you speak to the importance of these policy interventions and how they compare to the proposals that are currently in front of this committee that my Republican colleagues are putting forth? And if there are differences in the approaches and if there's a cost shift that will take place for Americans.
Yes, thank you for the question. So the number one reason why we are in an affordability crisis in private health insurance is the prices that commercial health plans are paying for healthcare goods and services, particularly hospital services and prescription drugs. And one of the reasons for that is consolidation, a lack of competition, particularly in the hospital sector. So the Congressional Budget Office has looked at this issue, and they have identified 3 major policy areas that could help reduce costs for commercially insured people. And they looked at directly or indirectly regulating prices, hospital prices, and that will have the most impact on affordability. But reducing anti-competitive behavior like clauses in provider-payer contracts that restrict competition, that could also have an impact, as well as price transparency. Those will get at the underlying drivers of healthcare cost growth in this country. Policies that simply move the deck chairs around on the Titanic and lower prices for groups that have healthier workers or younger workers will simply just create new winners and losers, with the losers being employers that have workforces that aren't quite as healthy or older than their peers.
Through this hearing, our Republican colleagues have been calling for the expansion of so-called associated health plans, claiming this policy change that will make healthcare more affordable. In your written testimony, you pointed out that some AHP sponsors claim to achieve lower premiums because they somehow exercise market clout. Can you tell us what evidence is there that they are actually negotiating lowering prices with healthcare providers? And if that's not how they are saving money, how is it exactly that they're able to lower prices?
Sure. So first of all, there's nothing preventing small employers, large employers from banding together to form purchasing coalitions. There are examples of that in states that have been very effective. The way AHPs lower premiums is by attracting healthier employer groups and using what's called claims experience rating. They look at the claims of each individual employer group to set the premium rate. So if you've got a healthier group, you get a lower premium. That really doesn't do anything to address the underlying driver of why healthcare is so expensive, which my colleague, Ms. Strauss, articulated so well, which is prescription drug prices and hospital costs. Thank you.
Thank you so much, and thank you all for being here and for your testimony. I do hope that we do get the opportunity to actually look at some of these bipartisan interventions and some of the policies that are proposed by CPO to actually address the rise of healthcare costs and so many people that are in desperate need of relief in our country. So thank you. I yield back.
Thank you, Representative Omar. And now I'd like to recognize my friend and fellow Virginian, Ranking Member Scott, for 5 minutes.
Thank you. Thank you, Mr. Chairman. Appreciate you calling this hearing. I'd like to ask Ms. Corlett a couple of questions. First of all, we've heard a lot about businesses. One thing we did in the Inflation Adjustment Act was to eliminate the so-called cliff on premiums under the Affordable Care Act. Can you explain how that would help a small business?
So by cliff, do you mean the for people over 400% of poverty?
Exactly.
Sure, absolutely. So the Inflation Reduction Act says for people who are essentially middle class, about 4 times the federal poverty level, they won't have to pay more than 8.5% of their income towards premiums in the marketplace. So for small employers or individuals or self-employed individuals who have income at that level, they are their premium contributions are capped at 8.5%, which is financial relief for a significant number of
Now, if they were just over the 400% of poverty, which is a little over for a family of 4, a little over $100,000, what could a policy cost without any subsidies?
Without any subsidies. In the individual market, for a family of 4, without any subsidies, I think you could be anywhere close to 20,000 a year.
And if 20,000, and if they are just over the limit and are limited to 8.5% of poverty, it goes from 20,000 to 8.5. And that would be particularly helpful to individuals in business for themselves, particularly helpful to families in small business. Back to the AHPs, you've talked about the fact that the premium is set at something actuarially sound for that group, which means if the group comes in and they evaluate it and they get a price which is higher than average, what happens? Nobody will buy the policy if it's higher than average. If it's lower than average, then they might benefit. And is that what you mean by cherry pick?
Correct. If you have an employee group that is healthier than the average group in the fully insured market, you're likely to find a lower rate with an AHP.
And when they come out of the general pool, what happens to the average cost in the general pool?
Sure. So actually, there's an actuarial analysis that was done of the Trump administration rules, and they found that on average, the folks that would come into the AHP market would be about 54% healthier, meaning less morbidity in the AHP market than in the fully regulated, ACA-regulated market, and that would increase prices by about 4.4% for plans in the ACA-regulated market.
And so if you don't get in one of these plans and you allow people, healthy people, to pull out, everybody else's premium goes up.
Right. What happens is what we call an adverse selection dynamic, where healthier groups go into the AHPs and groups that have older or sicker workers are left in the ACA-regulated market, and over time their premiums will climb every year.
And what happens to an AHP if suddenly somebody gets sick and the rates go up and they start charging more than average? Are the people in the AHP required to stay there and pay those higher prices? Or can they jump back into the pool and pay the average prices?
Sure. So because in the AHP, they can look at the claims experience of each individual small employer group. If you have a group that is generating more costs, their prices will go up because it's underwritten, and they may choose to go back into the ACA-regulated market, which, of course, if they have high claims costs, will increase the morbidity in that market.
And so while everybody else left behind pays higher prices when people pull out, they're essentially providing backup insurance. So when things go wrong and prices go up, they can jump back into the pool when the prices go up. Is that right?
That is a very fair characterization.
Now, there's a thing called cost shifting. The fact because of Obamacare and the Medicaid expansion, we have the lowest uninsured rate in history. What does that do to everybody else's insurance cost?
Well, we know before the Affordable Care Act that providers had a lot more of what we call uncompensated care costs, and they were essentially shifting those costs onto the insured population at a cost of about $700 per family per year. So the Affordable Care Act, by dramatically decreasing the uninsured rate, has reduced providers' uncompensated care costs and the amount that they shift onto the insured population.
Thank you. Mr. Chairman, I ask unanimous consent that I enter 2 documents into the record. One is the letter signed by 25 patient and consumer organizations expressing concerns about associated health plans and creating an accepted benefit exemption for telehealth only plans. And a second is a statement from Families USA that, among other things, concludes that, and I quote, proposals to expand the use of health plans that are exempt from state and local regulations do not address the fundamental causes of our health care affordability crisis.
Without objection.
Thank you. Yield back.
Thank you, Congressman Scott. And without any further witnesses members other than myself, I'm going to go ahead and ask a few additional questions. Again, thank you for all of our witnesses for being here. One comment I will add as a member of Congress, a lot of people don't know that members of Congress are forced onto Obamacare. And I guess I'll use that term loosely, we deserve to suffer under that which we have placed the American people. I have the highest health care premiums I've ever had, far and away. It's $1,300 a month for just my wife and I. And we are a healthy 50-something-year-olds. And so we are experiencing firsthand for the first time the peril of Obamacare, the lack of choice, competition, transparency, accountability that plagues our healthcare system that contributes to these higher rates, not to mention the fact the country's going bankrupt and we can't afford what we're doing from a government provision standpoint. Mr. White, I want to ask a quick question of you. One of our members asked Ms. Corlett if the price caps on insulin was causing premiums to go down. She gave a very specific answer and said, for diabetics. Is the price caps on insulin causing premiums to go down for everyone?
No, CBO estimated that premiums would increase and fewer options would be available.
Yeah, I thought so. Thank you very much. Ms. Watts, why is competition a good thing in the healthcare marketplace?
Competition is good everywhere, but with the lack of competition, we see things happening like we've described already today with the unfair billing practices where, providers can charge what they want to for services, and the savings that consumers could benefit from site-neutral payment reform, from focusing on more transparency with billing are enormous, depending on whose estimates you look at, hundreds of millions of dollars.
And we're talking about the debt ceiling here, negotiations. Someone mentioned earlier, government's bankrupt, $32 trillion national debt, running deficits every year, record levels. Who ultimately bears the cost if government's paying out more in health care payments?
We do.
Yeah, absolutely. The consumer does. And how about at the astronomical billing by hospitals? How does that affect care for patients?
Well, there's 2 things. First of all, when the cost of care goes up, some people will forego care, and that actually is more detrimental and more costly in the long run. There's many studies that have proven that. Secondly, we're all very familiar now with the actuarial value of a plan. It's basically what the plan pays and the consumer pays the remainder. And so the higher the cost is, that actuarial value is the same. It's just that what we're all paying goes up.
What's this legal price gouging impact on doctors, do you think? The hospital costs, the dishonest billing that's going on?
I'm not exactly sure, but I thought it was interesting in the prior questioning about the uncompensated care. I don't recall seeing trend go down as a result of the drop in uncompensated care. So I'm not really sure where all the money goes.
Ms. Strauss, thank you, Mrs. Watts. Ms. Strauss, I thought it was interesting when it was said earlier that consumers might not understand they were getting just a telehealth standalone policy. I don't know how anyone wouldn't understand that or would be fooled by that. But my colleagues on the other side of the aisle seem to think that if a plan doesn't cover exactly what the federal government says it should cover, then it's a junk plan. Given your professional expertise, what sort of value do employees get when employers have more flexibility in the coverage they can offer? What's the value to employees?
Yeah, well, employers are always coming to the table to try and find solutions for their employees. So even if a part-time employee does not have access to health care, rolling out a telehealth plan is something Otherwise, they would have nothing. So when we look at the telehealth specifically, most of the plans that people are accessing right now are actually in part of their health insurance policies. And so they do have great coverage through those. They are not for everyone. There's going to be situations where you need to actually go in and see your provider. But those telehealth services helped significantly in Iowa around the mental health space. And so, again, agents are extremely important. We are not only working with employers, we are actually working with the employees on a daily basis to make sure that when policies are rolled out like this or plans are rolled out, that it's communicated and they fully understand what they have.
Thank you very much. You know, I think my friends from the other side approach, they think that it's our responsibility to protect Americans from themselves. It's our responsibility, they think, to provide for Americans. That's the government's responsibility, they do believe. But also, they come from a mentality that employers don't care about their employees, when actually most employers really do care about their employees, want them to be happy and satisfied, safe and well with the health care they receive, as Mrs. Watts spoke to specifically. And so with that, we will conclude our questioning of our witnesses. I'm sorry, I didn't see Ms. Manning had slipped in. So now we will go and recognize, my time has concluded, we will recognize Representative Manning from North Carolina for 5 minutes.
Thank you so much, Mr. Chairman. Mr. Chairman, I would like to point out that the Inflation Reduction Act put a cap on the price of insulin for seniors, and as a direct result of that act, which was supported by House Democrats and signed into law by President Biden, 2 major manufacturers of insulin, Eli Lilly and Novo Nordisk, have already announced that they are reducing the cost of insulin to $35 for everyone. So the law we passed has already had an enormous benefit for everyone who needs insulin. And I'd like to stick with that, the Inflation Reduction Act, and to ask Ms. Corlett, can you give us your assessment of the IRA's emphasis not only on capping out-of-pocket costs, but also on lowering the underlying prices of drugs like insulin?
Sure. So full disclosure, I am not a Medicare expert, but I think one of the key pieces of the Inflation Reduction Act was to empower Medicare as a purchaser of prescription drugs to negotiate for a selected set of drugs on behalf of their beneficiaries to try to get a lower price. That's something that Medicare had been barred from doing. Obviously, the law is just being implemented, and so it will be a while before we see the full fruits of that negotiation power. But I do think there's unfinished business because I think many employer plans could also benefit from leveraging that negotiating power against drug manufacturers.
So in other words, extending these reforms to private health plans, including employer-supported plans or employer-sponsored plans, could help make drugs more affordable for consumers and businesses.
Absolutely.
In your testimony, you raised the problem of anti-competitive behavior in the prescription drug industry, including financial practices that disfavor low-cost generic and biosimilar drugs that drive higher prices. This is concerning to me on a personal basis. I myself had to fight for the coverage of my daughter's medication, which my health insurance company gave me the runaround on because it was going to cost $10,000 a month. And fortunately, I was able to win that fight, but I know so many other people don't have the knowledge or the wherewithal to keep fighting when they should be getting medications covered by their health insurance companies. So at the level of pharmaceutical manufacturers, how can we ensure that lower cost biosimilars are able to enter the market without interference from brand name manufacturers? Can you talk to us a little bit about what happens, what some of the brand manufacturers do to prevent those generics from coming to the market?
So, Congresswoman Manning, this is also a bit outside my expertise, but I can say that there is evidence that pharmacy benefit managers often hold on to a significant portion of rebates from drug manufacturers that should be passed on to employers' health plans, and they often can disfavor generic drugs if they don't come with rebates relative to higher cost prescription drugs.
Thank you. And Ms. Strauss, I saw you nodding your head on that one. So I wonder if you could comment on that and also talk to me about the problem of transparency in the pharmacy benefit manager industry.
Yes, actually, specifically in Iowa, we've been trying to address this on the state level. And last session, we were successful in getting some transparency legislation passed. So we are really excited to start to dig into the information that we're receiving from the pharmacy benefit managers. I can tell you we cannot solve problems if we don't go to the root cause of the problem, which truly is the drug manufacturers. When we have medications that are truly life-saving, like for instance for your child, if it's $10,000, why is there not competition out there? Why are they holding on to those prices? So when we throw around words like cap, it makes me anxious because a cap to me means you're telling the insurance company they can only charge $35. Well, the manufacturer is still charging that full price through. Those are going to always feed into the premiums. That's going to, one way or the other, everybody is going to end up paying for that. So if we aren't able to address it directly with the drug manufacturers, and I am very excited to hear the progress on the insulin side of things because I do work in the Medicare market and we have a lot of people that are on insulin. So that is exciting if that can drive change where the manufacturers are actually reducing the costs across the board for everyone, then that is going to be a solution. But if it's just capping through insurance, insurance is a middleman. The prices are still what they are behind the scenes with premiums.
I have to agree with you. It is very exciting that the law we passed to cap the price of insulin for seniors has resulted in the cost of insulin being reduced for everybody, and we can only hope that that will continue. We are facing a mental health crisis, and we know that telehealth has become a key avenue for mental health services. In my 10 seconds I have left, Ms. Corlett, how can Congress ensure that part-time workers have access to some form of telehealth, particularly for behavioral health?
Well, there's nothing preventing employers from offering part-time workers access to a health benefit with telemedicine. Also, if you're not offered an employer-based plan, you can choose to buy a marketplace plan, and many of these marketplace plans are also covering telehealth services.
Thank you. My time has expired, and I yield back.
Thank you, Congressman Manning. And without objection, before we close, I enter in the record letters supporting efforts to enhance health care affordability from the following organizations: Americans for Prosperity, bipartisan organizations supporting site-neutral payments, the American Hospital Association, the ERISA Industry Committee, the National Association of Benefits and Insurance Professionals, NFIB, and the Partnership for Employer-Sponsored Coverage. Again, I would like to thank all four of our witnesses for taking the time to testify before the committee for this very important issue today. Without objection, there being no further business, the committee stands adjourned.